To start off with saying, I don't know whether Dr. Pinsky remembers me, but from many years ago I was his student. I did work for a couple of years at the University of Pittsburgh, and naturally it puts us into a little bit of a disadvantage. Coming from the culture that respects its teachers, I have to apologize to you if I win this debate, Dr. Pinsky. So start with that, with the classic Guru Sishya tradition of saying that I don't want to win it, but if I do, sorry. Okay. And the second aspect of it is beginning a debate at any time has got to really require a little bit of reading of his mind to anticipate what he's going to say, and that can be a little bit of a dangerous trick. So the advantage I distinctly have under these circumstances is the fact that I can read Dr. Pinsky's mind. It's very transparent. He's published quite a bit, and I know exactly what he's written about, so it gives me a little bit of an advantage over there. In contrast, my opaque head can't be read, and in fact I can resort to guerrilla tactics, if you want to call it that. Confuse, confound, confabulate, and run away before anybody recognizes that your arguments are not very strong. So that's basically what I'm going to do right now. Let me start with the argument that I don't use PA catheters anymore. You can't see the line very well, but I can illustrate it very, very clearly. In the last several years, my use of PA catheters in my intensive care unit have declined to a dramatic value of 0 per year. And the fact is, it's not associated with other procedures declining. So clearly, it has been a selective reduction in the use of PA catheters from a frequency that was close to about 1 in every 6 admissions in a general ICU to something that has come down to 0. So before you accuse me of the fact that I'm another sheep, basically trying to follow what the rest of the world is doing, nobody else is using the PA catheters, at least let me establish my pedigree. I was born in a setting, rather. I worked for a long time with Professors Swan and Gans, and it is something that I grew up with, and I respected it for a very long time. So you might consider me some kind of an apostate. But here, at least as far as science is concerned, having a difference of opinion or breaking away from your religion is not such a bad thing. And I hope I can convince you that what I'm doing right now is really breaking away from the religion after a reasonable amount of thought about why I shouldn't be using the PA catheter. The PA catheter, yes, it was sliced bread, there's no question. The convenience of the PA catheter is fantastic. You could measure preload, particularly not just preload, the preload of the left heart with a wedge pressure. Let's call it the wedge right now. The cardiac output could be easily measured by thermodilution, and you really had a good handle on the hemodynamics of the patient. It seemed very satisfying in that sense, and at the same time, when this PA catheter got more and more popular, there was a lot of work from people like Dr. Shoemaker, who very clearly demonstrated that what you see under most situations, stress and sepsis, for instance, is going to be an increasing oxygen demand and a goal that is directed towards increasing this delivery of oxygen, mainly at titrating up your cardiac output, would be very well relevant. And the initial studies were quite impressive, particularly in the surgical setting, that to the point we were very satisfied that we had a catheter that could allow us to do all of this. But did this stay? I think about the same time that there was a growth in the use of the catheter, the criticism also began. I still remember the very shrill arguments that you could come from Professor Eugene Robin, which used to antagonize Professor Swan all the time. But besides that, there were a lot of logical people who were thinking it out at the same time and arguing that what we were seeing, say, for instance, with end diastolic pressures are not necessarily good correlates of end diastolic volumes. And effectively, when you looked at it, you were assuming far too much. When you're trying to judge the responsiveness of a ventricle in terms of preload manipulation, you're trying to use a pressure, which naturally was a multiple step extrapolation. And it didn't work very effectively. And Dr. Pinsky will agree with me that preload adequacy ought not to be judged by a specific value of the preload, but how the heart responds. And that has to be done in a dynamic fashion. I'm quoting his papers again. Very, very clearly, the wedge pressure has got no predictive value in terms of judging what your preload adequacy is. And so clearly, the measurement of preload, the wedge pressure, and the myth behind it is gone. What about cardiac output? It fell through the same kind of fate. After the initial optimistic studies of Dr. Shoemaker, I think we saw subsequently that when we goal-directed our therapies against a specific cardiac output kind of a goal, not only did we have no benefits, there were occasional times in some studies, very clearly, we were hurting the patients by this kind of a process. And effectively, we came to the argument that even measuring cardiac output is of no value. Or if I wanted to summarize in the famous terms of the famous Jackie Chan and Chris Tucker, what is the value of cardiac output? Absolutely nothing. So if I come to the same conclusion, I said this catheter was invented so that you could measure preload and measure cardiac output, and we argued that over a period of time, neither measuring the cardiac output nor the preload was of any value. So what is it really good for? I'm again trying to attempt to read Dr. Pinsky's mind. He's going to argue that it's probably necessary for the monitoring of mixed venous saturations. It's going to be very valuable for PA pressure measurement and right heart pressure measurements, and maybe the wedge pressure to differentiate between capillary leak and pulmonary edema from other causes. But let me start with the first one a little bit, because it's going to be based on a certain presumption. There are no studies that show you that measuring mixed venous saturation is of any value. Yes, the PA catheter is the one way in which you can do it. But we are extrapolating from that famous reverse study, which looked at mixed venous saturation, and then saying, if mixed venous saturation works well, why not? Central venous saturation works well, mixed venous saturation should also work very well. And is there a good reason for this argument? I would argue that it is physio-illogical under these circumstances, where in sepsis, the mixed venous saturation is probably more clearly dictated by what happens at the tissue extraction level rather than by the global hemodynamics. And to use the mixed venous saturation as a method of titrating your global hemodynamics is going to be a very poor system, because it's not going to be a good tracker of the adequacy of your hemodynamics. So why is it so popular? Again, it comes to the same single study, which is the famous reverse study. And I just want to punch a few holes into the study to see if I can get out of this in some way. The first thing about the reverse study is you look at it, and it was a CVP-based fluid titration. You, I, and Dr. Pinsky will agree that basically the CVP is not a great way to adequately resuscitate a patient. Imagine just titrating up to about 8 to 12 millimeters of mercury and being happy with that CVP. Highly likely that you are under-resuscitating a large number of patients. You take a bunch of patients, you're under-resuscitated with fluid, subject them to vasopressors. Why won't you cause a mixed venous desaturation? You will. Of course you will. And that's exactly what happened. You look at this, the frequency of mixed venous desaturation in this reverse study can be estimated by the amount of RBCs that they use, and that's about almost half the patients required had a problem with mixed venous desaturation. And most of them recovered when you gave them a little bit of blood. They didn't require dobutamine, suggesting again that they were all under-resuscitated. And when you gave them dobutamine, you did something else that is very interesting. That is, when you gave them the dobutamine, you were vasodilating these under-resuscitated patients, and then you fill them up with large amounts of fluid, which is very clearly demonstrated in the paper. The single big change between these two groups, one in which you gave the dobutamine, one which you didn't, was about 1.5 liters of extra fluid that you had to give to them. So effectively, you took a group, under-resuscitated them, killed them off. Actually, you look at the mortality is much higher in the baseline in the reverse group than compared to other studies. The frequency of mixed venous desaturation is disproportionately high. And I would argue that at least under conditions of sepsis, it is neither logical nor appropriate to target a mixed venous saturation. So I'll go with that. What about the pressures? There are so many other tools for measuring pulmonary pressures. And the reasonable correlations that exist with echocardiography seem to be very fair. And in addition, when you talk about right heart function, I think the qualitative information that you get from right heart contractility studies, basically looking at septal kinetics, looking at right ventricular volumes, have far greater and intuitive value about assessing right ventricular function than just measuring the PA pressures. On the other hand, what about the issue related to measuring the wedge pressure? Yeah, I think there is an argument there that the wedge pressure, which is an important pressure, you have to measure the pressure if you want to look at the hydrostatic changes, and it does allow you to make some kind of differentiation between leaks and cardiogenic causes. And can we substitute this? Again, very nice data from Dr. Lichtenstein's group very recently that shows you that you can use ultrasound parameters of the lung to make a reasonable differentiation between leakiness and not leakiness, or certainly in terms of the correlation between wedge pressures and the leakiness. So this is again, I think, besides the point. Yes, there are many physiological reasons and there are a lot of measurement reasons that don't want to use the PA catheter. But is there an outcome difference? And this is where we're going to really look at it. Not a single study in the recent past, whether it is in high-risk surgical patients, whether it is in sepsis, or whether it is in ARDS, has demonstrated any outcome differences from the use of the PA catheter. So you could always argue, how do you expect a test to change an outcome? And this is usually by this argument: the PA catheter is a test, the CT scan is a test, the PA catheter is therefore a CT scan. CT scans don't change outcomes, PA catheters should not change outcomes. This can be extrapolated to the famous Aristotle is an animal, the horse is an animal, and therefore Aristotle is a horse. The kind of logic that we are applying right now is exactly that. There are tests and there are tests. There are animals and there are animals which are different from each other, and we need to really understand that the proximate harm that you can get from a PA catheter is significantly different from any kind of harm that you could get from a CT scan. And we need to look at that harm in a situation where there is no benefit before we say anything else. And everybody who looks at this famous Connors study, it shows you a nice demarcation between survivals with a PA catheter and without one, will criticize it as the fact that it was an observational cohort in a large unselected group where there was a significant overuse of the PA catheter. Fair enough. So how do the randomized controls trials stand out? There are at least 4 trials that I need to look at. 2 of them were too small to even detect a difference of about 10% in mortality between the studies. The other 2 just barely meet that kind of criteria. But just look at the divergence of these lines. The PA catheter continues to remain worse than the non-PA catheter, even in the studies which are allegedly not significant. My argument is, it is possible that you may have a small difference in mortality present still. And my argument will be that even one excess death in the absence of any benefit should be considered unacceptable, because the risk-benefit ratio becomes infinite. And that is the point. That is taxation without representation, which started your revolution in America. And I think basically that's exactly what we're facing. Is there any risk with the PA catheter? Yeah, look at the studies. Sandom study, which looked at no differences. All the pulmonary embolism occurred in the PA catheter group. There was none in the other group. What about renal dysfunction? In at least some of these studies, there seems to be a mismatch of some kind. So it is not that the PA catheter has no negative effects and the benefits are very marginal. Dr. Pinsky will advise me that if I need to use it, I need to learn how to use the catheter effectively. But imagine the amount of effort that I should go through to get a single PA catheter reading. I have to zero level appropriately. To what? I don't know. Measure the patient in the supine position. Don't keep him in any other position. Measure it at end expiration. Adjust for a transmission index. And then be there at the bedside for every single reading of the PA catheter. Don't expect somebody to read it. And basically, most of us don't do that. And really, I would suggest that another way of improving yourself is to learn another technique, such as the echo, that might give you exactly the same kind of answers, and you can get away with not hurting your patients from the PA catheter. Small obituary over here. Kathy, PA catheter, Swan-Ganz, has died. Please let her rest in peace. Don't resuscitate her at this point in time. Thank you.